When nature needs a hand. So this topic is going to include discussing things like induction of labour, many reasons that we might offer that. It's also going to talk about instrumental birth, be using forceps or the suction cup, which is called the ventouse. And we're also going to explore about caesarean section. The reason for including this in parent education classes is actually not to make you anxious or worried, but actually quite the opposite, to give you some information, to frame it and put it into perspective. And as you sit and prepare with your birth partner how you hope and envisage your baby's journey of birth to be, likely that we're all sat thinking about a lovely straight road where actually I have, all my preferences and choices and everything goes swimmingly and I get my baby at the end of it. But sometimes it's difficult to predict that road will stay straight. And for some ladies, it can take a bit of a twist or a turn. Many ladies will have a straight road, and if you've looked at these topics, will never need to consider them. But for the few ladies that make a bit of a twist or a turn before they get to the end of that journey and having the baby in their arms, we can give you some information to understand why these things might happen and how commonly they happen. And typically when I talk to couples who have been to parent education classes after they've had their babies, they may say, our baby did need a handout with a ventouse, and actually as we sat and learned about that in class, it felt a little bit daunting. But because that actually was something we encountered on our journey of birth, we actually felt better equipped because we understood a little bit about it, we knew what was likely to happen, and we knew that we were in safe hands. So try to kind of think about this bit that, you may never encounter them, but that if you do, that actually knowledge is power, and understanding a little bit about them may make you feel more empowered and less anxious at the actual time. There may be many reasons why it is suggested that we go for an induction of labour. A common one is going past your due date. Remember what that stands for, estimated due date. It's not an exact science. A date given to you perhaps based on the first day of your last menstrual period, perhaps based on the first scan in pregnancy you had. It's an idea, but we need to work with this date to plan your pregnancy care. So it could be that you get to what we call term plus, so that date comes and goes. Or it could be that you're advised induction of labour for another reason. Perhaps it is that your baby's growth has been a little bit slower than expected for the gestational age. Or perhaps they get to a stage towards the end of pregnancy where the growth is kind of become a little bit static and not as good as it should be. Or it could be that scan has found your baby's size and weight to be less than expected for their gestation, and we say that you have a small for gestational age baby, and that we advise to not go past your due date and to have an induction. Perhaps it could be that you've had a complication in your pregnancy, perhaps raised blood pressure or gestational diabetes. Or maybe it is that on fundal height measurements, we predicted the baby was going to be large for gestational age. You've then come along for a scan, and the scan has predicted that your baby will be large for gestational age, or expected to be large for gestational age, and they advise to have an induction of labour. Or it could be that actually your waters have gone and that you haven't gone into labour by yourself, so that we then advise that we help the process along by inducing your labour. If you are having an induction of labour because you have gone past your due date, remember, as we said in previous videos, the importance of baby's movements. Remember that movement should still continue in the same pattern to your due date, past your due date, and right up through birth. So it's even more important perhaps when you've gone over your due date that you're mindful of your baby's movements. Why can't we just wait and wait till the baby arrives? Well, it's thought that the placenta is perhaps designed to function efficiently for around 43 weeks of pregnancy. So as we're going way over into that third week of being overdue, we start to wonder how well the placenta is functioning. Typically at Harrogate we would offer induction at term plus 12 unless there was a good reason for doing it sooner. What you may be offered is once you get to that due date and become post-term, your midwife may offer to perform an examination vaginally to try and assess the cervix as to how ready it is to go into labour. Before it starts to make changes, the cervix is tucked backwards, 4 to 5 centimetres in length, thick and tubular. By doing a vaginal examination, the midwife can reach the cervix and assess how many of those changes has it made. So has it started to come forward? Has it started to lose some length? Is it softening up a little bit? The cervix feels a little bit like the difference between the end of your nose if it's quite firm and your lip if it's nice and soft. So the midwife is making an assessment of all these things. This examination could be carried out at home or at your GP surgery, if you happen to be an antenatal clinic for an appointment, or a maternity assessment centre. And with your first baby, we would typically offer it at 40 weeks at term. It can be a little uncomfy, so the midwife will encourage you to have an empty bladder and to rest back and to take some deep breaths. If at any point you find the examination too uncomfortable or you want us to stop, you just say stop and we will end the examination there. It could be that the midwife performs the examination and actually that cervix just hasn't really started to make changes for birth yet. It's still quite tucked backwards, and on the examination we can only just reach it. So we'll need to have made a little bit of change for us to offer what we call a stretch and a sweep. If you look at the little image, you will notice that the baby in the bag of waters, the bag of waters comes down and attaches to the neck of the womb or the cervix. A stretch and a sweep is a process of trying to loosen that balloon or bag of waters away from the cervix. So it's not breaking the waters, it's just trying to loosen the bag away from the cervix. And we know that that likely increases a production of hormones that can encourage your birth to start. The process itself of doing a stretch and a sweep may cause you to have a show. So the show is that plug of mucus that sits in the cervix. If we've been able to gently get a finger in there and to stretch it and to sweep the bag of membranes away from the cervix, that is likely to cause a show. It might be quite heavily pink, a little bit blood stained. The fact that it's really, really mucousy tells you that it's a show. And it could mean that it helps your body prepare for birth. The next step would be a medical induction. So the many reasons we've talked about why you may need induction, or you've got to term plus 12 and there's no signs of baby coming. Some couples may choose that actually, for whatever reason, they don't wish to accept an induction at term plus 12. And that would be a means of having a discussion with your midwife and possibly one of our obstetric consultants to explore the pros and cons of both waiting or having induction. For a couple who are perhaps choosing to wait for some time, it may be that we offer some additional monitoring for your baby to reassure us of their well-being. So the CTG, the two belts that go around your abdomen that monitors baby's heart rate for 20-30 minutes. Or perhaps if you're wanting to wait a prolonged period of time, we consider having an additional scan to measure your baby's growth, the amount of water around your baby and the blood flow through the placenta. So for example, we've got to 12 days past the due date and there's not really been any signs of baby coming. I've perhaps had a stretch and sweep at 40 weeks. I maybe had a second one at 41 weeks, but actually I haven't gone into labour by myself. At that point, we would give you that date, 12 days past. Induction of labour takes place on panel ward. So in the morning, the midwife in charge for the shift would give you a ring and let you know what time we could accommodate that induction. So it might be that we say we can get on with it this morning, or actually for ward activity, we're not in a position to start things perhaps till this afternoon or this evening. We would then invite you in. We would do some assessments of mum's well-being and of baby's well-being. At the minute, your partner is welcome to join you for the first couple of hours of the induction process. This is something that is constantly changing with the advice on the COVID pandemic, so do ask your midwife for the latest advice. You would come in, we would do these checks, and then we would see how ready the cervix was again by doing a vaginal examination. If the cervix hasn't made much change, then we would pop a medication in there called Propess, and you'll be able to see this on the slide. Propess is like a little flat tampon that sits behind the cervix for up to 24 hours and slowly releases some hormones to help encourage the cervix to finish off making those changes for birth. So coming forward, losing the length, thinning, softening, shortening. If you are a straightforward term plus 12 induction, it is possible to have this first 24 hours of the induction process at home once the Propess is in place. We would ask that you don't live too far away from the hospital, so around a 30-40 minute drive, and that you had your partner with you at home. The benefits of going home is actually that you are likely to get more rest and feel most relaxed and most comfortable. And if you've happened to see the video on the birth environment and my discussion about the hormones, we know that your hormones will work best in an environment where you're comfortable, rested and relaxed. If you do choose to go home, the midwife would give you a prescription for a small dose, a few doses of codeine. Codeine is a pain relief that you can take alongside paracetamol, and sometimes the pessary can give you a period type discomfort that's not labour yet, but some ladies may find uncomfortable. You can bath with the Propess in, and you could take the paracetamol and codeine. If you do choose to go home, we don't give your bed away to somebody else. It stays your bed, and then if at any point during the induction process you wish to come back to hospital, then you just come back in. At 24 hours, if you haven't got the onset of regular contractions, the pessary is removed and the vaginal examination is repeated, and we see how much change the cervix has made. If there's little or no change, we would then put in a second pessary for a second 24 hours. At this point, the induction process continues in hospital. We wouldn't encourage you to go home for this second 24 hours. The Propess is there for 24 hours again. So now we are 2 pessaries, 48 hours into the induction process. And if labour still hasn't started, we take that second pessary out and we check the cervix again to see whether it's made any change. What you have to remember with all induction processes is we're trying to get your body to do something that it just may not be ready to do. So actually it can take some time. It could take anything between 24 hours and 96 hours. And the more you can relax and keep comfortable and keep patient, the better chance that the medication works, rather than you getting frustrated and tense. So 48 hours in, 2 pessaries, we will do another vaginal examination. And this examination would be to see if the cervix had made enough change for us to break your waters. The little slide will show you the little hook that we use to do this. So it's a vaginal examination, and just like popping a balloon with water in, if we are able to, we break the waters start to come away, and then we would encourage you to be mobile for a couple of hours, and hoping that being active and mobile with the waters having broken brings on the onset of regular contractions. Or it could be that actually 48 hours, 2 pessaries, we examine the cervix again, and actually it's still quite tucked back and not quite opened yet, and it's not actually possible to break your waters. For those ladies, we would then discuss with you the merits of having a period of rest, so maybe 12-24 hours of rest, before considering a third pessary if we still weren't able to break your waters. So what can you do to make this process comfier? Keep patient. If it happens sooner, then great, but actually it might take some time. Consider the outpatient induction for the first 24 hours if your induction of labour is a low risk term plus 12 induction. think about things you can use to distract yourself and to keep yourself comfy and rested. Listen to your body, rest if you feel like you need to rest, otherwise be active and move around, because that might help bring labour on. Maybe bring some things in to help with distraction, book, magazines, maybe something you've got on a device to watch a box set or a film to take your mind off it. Maybe to go for a little bit of a wander around the unit or around the hospital to keep active. And remember, the more patient, the more relaxed you are, the best chance it is that the process will work. So we've talked about the pessary, we've talked about breaking your waters. After the water's been broken and been active, if after a period of around 4 to 6 hours you hadn't really started to have or experience any regular contractions, the next step would be to add in a hormone drip. And the hormone drip is an artificial version of the labour hormone oxytocin. It's called syntocinon. We would ask to pop a little cannula into the back of your hand so we can connect the drip up to it. And we're trying to simulate regular contractions. So to get the uterus to a point where it's contracting probably about every 3 minutes and lasting a full minute. At the outset of starting the drip, it's impossible to predict how quickly it will take your body to respond to it. So it could be that you're on the drip 2, 4, 6, 8, 10, 12 hours before you start to get regular contractions. That's the piece of string finishing off, and then you will still potentially have 6 to 12 hours of regular contractions at that point. The drip is started at a really low level, and the midwife will carefully titrate the dose to achieve regular contractions. It's important that we monitor your baby's well-being whilst we're using the drip. So we would ask if we can continuously monitor your baby. So this would be the 2 belts that go around your abdomen, and we use a CTG machine to monitor your baby's heart rate continuously and to monitor any tightenings or contractions from the uterus. And that will continue till your baby's born. Having continuous monitoring and having the use of the hormone drip doesn't mean that you need to sit in the bed. In fact, quite the opposite. We'd really encourage you to be active, to be upright, forward and open still, because we know that that's going to hopefully help the process be shorter and comfier for you as you maximise that space in the pelvis. We do have a number of wireless monitors where you have the belts around your abdomen but you're not physically attached to a machine. If there isn't a wireless monitor available, you will have the belts around your abdomen and attached to a machine, but you can still stand, you can still squat, you can still be on a birthing ball, you can be in all fours. As long as we're getting that monitoring for baby to reassure us they're coping with the process, you can still swing from the chandelier, and we'd encourage you to. The drip will continue until you get the regular contractions, and then it will stay on that level until your baby's born. If you do need your labour inducing by using the hormone drip, all the comfort relief measures are available to you. The only one that you wouldn't be able to use would be the birthing pool. We wouldn't recommend that, but you can still use all the coping mechanisms. You could consider using gas and air, diamorphine and epidural if you wish to.